Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today we will be continuing our discussion of the management of rectal cancer with a discussion of the evidence base for locally advanced rectal cancer. If you recall from the overview lecture, we talked about how locally advanced rectal cancer is really considered disease that is stage T3 to T4 or node positive, so anything stage 2 or greater. And a T3 tumor is defined as a tumor that invades through the muscularis propria of the rectal wall and into the pericolorectal tissues, or the fat that surrounds the rectum. So as soon as the tumor is invading through that fat, it's considered T3, and anything that is T3 or T4 is considered stage 2 disease. Anything that is node positive is considered stage 3 disease. And so anything that qualifies as stage 2 or higher is typically treated with a combination of radiation, chemotherapy, and surgery. Now, this slide is borrowed from that last overview lecture, but if you recall, we talked about how the management of locally advanced rectal cancer has significantly evolved over the last several decades. And in that lecture, we kind of outlined how we went from answering the question, what is the best treatment, to what is the best sequence of radiation and surgery, and how do we fit in chemotherapy, to now wondering in the modern era, can we maybe do less treatments and looking at trials that are either pursuing omission of radiation or omission of surgery. In this talk, my objective is to show how that evolution has occurred in the management of rectal cancer in the context of all of the evidence. So I'd like to start with some older trials looking at the role of radiation in the pre-TME era versus in the TME era. Look at some trials looking at the sequencing of radiation and surgery. Also go through some trials that compare short course versus long course radiation. And then finally end with some modern studies that are looking at omission of one modality or another. So either omission of radiation or omission of surgery. Let's start by looking at some of the older trials that first showed a benefit to radiation when added to surgery. The current standard of care in terms of surgical approach for rectal cancer is something known as total mesorectal excision, or TME. This technique was first described in the 1980s, and it involves removal of not just the rectum, but also the mesorectum, which is the fatty tissue that surrounds the rectum and actually contains mesorectal lymphatics, which is one of the first places that rectal cancer can potentially spread to. So this surgical approach of TME was kind of revolutionary for rectal cancer, and it drastically improved outcomes of patients. In the pre-TME era, the surgery just consisted of removing the rectum, but not that mesorectum. In that pre-TME era, so now think pre-1980s, there were many studies that showed that when we add radiation to surgery, there's actually an overall survival benefit. And these studies are listed here in this table for your review. But as you can see, all of these studies included patients with T3 to T4 tumors, so tumors that were invading through the muscular wall of the rectum and into that perirectal fat, or node-positive patients, so really what we defined earlier as locally advanced disease. These studies were predominantly using long-course radiation, so conventional fractionation, and many of them were giving concurrent chemotherapy with that. The only study that was looking at short-course radiation was the Swedish rectal cancer trial, which was looking at short-course radiation of 25 gray and 5 fractions, and this is typically not delivered with concurrent chemotherapy. So long-course chemoradiation is delivered with concurrent chemotherapy, but short-course radiation is typically delivered on its own. So remember, these are two kind of paradigms that emerged in parallel. So long course radiation was predominantly used in the US and in Germany. Short course radiation was predominantly used in the UK and in Northern Europe. But regardless, all of these different studies that looked at the addition typically of surgery followed by radiation showed that there was an overall survival benefit to the addition of radiotherapy postoperatively. The Swedish rectal cancer trial actually looked at preoperative radiation, so pre-op short course radiation followed by surgery, and it did show an improvement in both local control as well as overall survival as well. So this is important for context, I think. In the pre-TME era, there was an overall survival benefit across many studies to the addition of radiotherapy, whether that was preoperative short course radiation or postoperative long course chemoradiation. In the 1980s then, as we said, the TME surgical approach was first described, and this drastically improved outcomes for patients with rectal cancer and kind of revolutionized their surgical approach, right? So now, after the 1980s, we're no longer just removing the rectum, we're also removing that mesorectum, so all the fatty tissue around the rectum that contains those lymphatics. I think the best trial that exemplifies the benefit of radiation in the TME era is this Dutch TME trial. So this was initially published in 2001, and then there was an update published in 2011. But this trial enrolled almost 2,000 patients with resectable rectal cancer within 15 centimeters of the anal verge who were not able to be treated by transanal local excision. So they included any patients that were T1 to T4, and they could be node negative or node positive. And they were randomized to 25 gray in 5 fractions preoperative radiation, followed by TME in 2 weeks, or TME alone. This trial showed that there was a significant local control benefit, but no longer an overall survival benefit to short course radiation given preoperatively. So the 10-year local control improvement was around 6%. So radiation kind of halved the risk of local recurrence. So with surgery alone, the risk of local recurrence was 11%. And with the preoperative short course radiation, it was decreased down to just 5%, and that was statistically significant. So you can remember that there was a 6% improvement in 10-year local recurrence, and adding radiation approximately halved the risk of local recurrence. They did not see any significant difference in overall survival. The 2-year survival was just around 82% in both arms. They also did not see any benefit in terms of disease-free survival. So it was really just a pure local control benefit that radiation was adding now in the era of TME. Radiation seemed to have more of a beneficial effect as the distance from the anal verge increased. So greater distance from the anal verge seemed to show more of a benefit to radiation. And they found that radiation did improve 10-year overall survival for stage 3 patients that had a negative margin. So remember, stage 3 are our node-positive patients. And if they had a negative margin, the radiation seemed to improve their 10-year overall survival from 40% up to 50%. And that was statistically significant. So the big takeaway from the Dutch TME trial is that with improved surgery, so now we have the total mesorectal excision, radiation no longer provides a survival benefit, but it continues to provide a significant local control benefit. The only subgroup that seemed to have a survival benefit was that subgroup of stage 3 patients with a negative margin. So the Dutch TME trial looked at preoperative short course radiation, 25 gray in 5 fractions. And with preoperative short course radiation, we really don't add concurrent chemotherapy. The reason for this is that we are giving 5 gray per fraction, which is a higher dose of radiation, so we worry about causing toxicity with concurrent chemotherapy. Also, it's a short treatment. It's only 5 treatments, so it's hard to give kind of an effective round of chemotherapy with such a short period of time. And so with short course radiation, it's typically radiation on its own. It's not given concurrently with chemotherapy. And short course radiation is the standard paradigm that kind of emerged from UK as well as Northern European countries, so Scandinavia. In the US and Germany, remember, the radiation standard that was emerging was conventionally fractionated radiation, so 1.8 to 2 gray per fraction, and we give doses of something like 50 gray in 25 fractions or 50.4 gray in 28 fractions. And with long course radiation, we do have an opportunity to give chemotherapy. It's safer because we're giving conventionally fractionated doses, so lower dose with each treatment. And we also are giving radiation for about 5 to 5.5 weeks. So we now have kind of more time to give a successful round of chemotherapy. So there's a couple of trials that looked at the addition of chemotherapy to long course radiation and showed that there was a local control benefit to concurrent chemoradiation with long course radiotherapy. So the first of these trials is a French trial, FFCD 9203, that looked at T3 to T4 rectal adenocarcinoma patients, and these patients were randomized to pre-op radiation, 45 gray and 25 fractions, with or without concurrent chemotherapy. So the chemotherapy that was given concurrently was bolus 5-FU with leucovorin on weeks 1 and 5. The study showed no significant improvement in overall survival, but there was significantly improved local control with chemoradiation. So the 5-year local recurrence rates went from 16% with radiation alone down to 8% with chemoradiation, and the rates of PCR improved as well with chemoradiation. The other trial looking at this question was the EORTC 22921 trial, and this had 4 different arms to the trial. So they randomized patients to preoperative radiation alone, preoperative chemotherapy alone, preoperative radiation with post-op chemotherapy, or preoperative chemoradiation with post-op chemotherapy. And that last arm, the preoperative chemoradiation with post-operative chemotherapy, was again the winning arm in terms of 5-year local control rates, which were as low as 7.6%. So the EORTC 22921 trial actually showed a benefit to preoperative long-course chemoradiation, followed by surgery, followed by post-operative chemotherapy. And again, similar to the French trial, there was no survival benefit seen in this trial. It was really a local control benefit. So with long course radiation, we know that adding concurrent chemotherapy improves local control. And so that is where we get that standard. For short course radiation, we typically don't add concurrent chemo, but for long course chemoradiation, we do add concurrent chemotherapy. So this was a lot of, I think, historical data here, but I think the big takeaways that we need to realize are, number one, we have 2 radiation paradigms that are emerging for T3 to T4 or node-positive rectal cancers. So those 2 paradigms are long-course chemoradiation, so typically 1.8 to 2 gray per fraction conventionally fractionated radiation given with concurrent chemo for about 5 to 5.5 weeks. That's our long course chemoradiation paradigm, which is the big paradigm in the US as well as Germany. And then we also have short course radiation, which was more commonly used in the UK and Scandinavia, which involved just 25 gray and 5 fractions radiation alone. And typically this was delivered pre-operatively. So we have these 2 paradigms, long course chemoradiation and short course radiation. And both of these radiation paradigms in the pre-TME era, so this is pre-1980s, when added to surgery, actually showed an improved overall survival benefit. So they not just improved local control, they also improved overall survival. When the surgical technique improved, however, so when we started doing TME standardly, in the TME era, all of the data that we have shows that radiation provides a local control benefit, but no longer an overall survival benefit in the era of TME. So this is very important when we're counseling our patients on the role of radiation in management of rectal cancer, right? In the era of TME, so in our modern era, radiation is not providing a survival benefit, but it is providing a significant local control benefit. And I think these are important numbers to know from the Dutch TME trial. Remember that the local recurrence went from 11% with surgery alone down to 5% with the addition of preoperative short course radiation. So big takeaways, understanding these paradigms of long course chemoradiation versus short course radiation. And then number 2, understanding that in the TME era, the benefit to radiation is a local control benefit, not a survival benefit. So that was sort of the first stage of that evolutionary journey we talked about, right? Kind of understanding what is the best treatment that we should be using for rectal cancer patients. So we've optimized our surgery with total mesorectal excision, And we've kind of worked on optimizing our radiation approaches. So the short course radiation in the studies that we looked at, it was typically given preoperatively, and it's given alone, not with any concurrent chemotherapy. For the long course chemoradiation, we realized that adding chemotherapy to long course radiation improves local control. So we give long course radiation typically with concurrent chemotherapy. And in many of the trials that we looked at, the long course chemoradiation was given postoperatively, so it was given adjuvantly. The next stage of the evolution was really trying to understand what is the best timing for our chemoradiation. And this is where an important study out of Germany comes in that looked at the sequencing of chemoradiation, so preoperative versus postoperative chemoradiation. And what we found is that preoperative chemoradiation improves local control. It also allows for more significant downstaging, so it can kind of decrease the aggressiveness of the surgery that we pursue. So let's take a look at that very important German trial. This German study, also known as the ARROW study or the AIO94 study, is an extremely important study looking at the sequencing of chemoradiation with surgery. So this trial ran from 1995 to 2002, and it enrolled about 800 patients with rectal adenocarcinoma, defined as less than 16 centimeters from the anal verge. They used ultrasound and CT imaging to rule out stage 1 disease, so they included stage 2 or higher patients, and they randomized them to preoperative chemoradiation, followed by TME, followed by adjuvant chemotherapy with 5-FU, or TME followed by postoperative chemoradiation, followed by adjuvant chemotherapy with 5-FU. So in both of the arms, the patients were receiving adjuvant chemotherapy. The question was, should we do preoperative chemoradiation followed by TME, or should we do TME followed by postoperative chemoradiation? In terms of the treatment details, all of these patients were treated with conventionally fractionated radiation, so 50.4 gray and 28 fractions, and they received a 120-hour 5-FU infusion, 1,000 milligram per meter squared per day, given weeks 1 and 5. The radiation planning was used 3D planning, so a 3-field or a 4-field box, and the radiation regimens were identical in both arms, except for a 5.4 gray boost that was delivered to the postoperative bed for the patients that were receiving postoperative chemoradiation. The idea behind giving a little bit of extra dose in the postoperative setting is that postoperatively there's a little bit of hypoxia, and so perhaps, we know that oxygen helps radiation work better, so perhaps we need to give a little bit of a boost when there's a hypoxic postoperative bed. The TME surgery was performed within 6 weeks for patients that received preoperative chemoradiation. And then in terms of adjuvant chemotherapy, they received 4 cycles of bolus 5-FU, and this was started 1 month after their local treatment. In the group of patients that received upfront TME followed by postoperative chemoradiation, one very important finding is that 18% of the patients were actually downstaged at the time of surgery. So these patients were thought to have T3 to T4 or node-positive disease based on the ultrasound and CT staging, but then at the time of surgery, they were in fact found to have T1 to T2 N0 disease. And that finding is really important because it's almost 20% of patients, right? And that tells us that we are probably over-treating 20% of patients in the preoperative chemoradiation arm because, if we knew up front that they had T1 to T2 N0 disease, then they wouldn't have needed radiation anyway. They could have just been treated with surgery alone. And so in this German study, we probably overtreated around 20% of the patients that were in the pre-op chemoradiation arm. The caveat of this, of course, is that this was in a pre-MRI era. In the German study, they used only ultrasound and CT imaging for staging. Now we standardly obtain MRIs on our patients, so we are kind of better able to assess whether or not they truly have T3 to T4 or node-positive disease. So the German trial, though, this commonly comes up, I think, in tests, and it's important to realize that Because we know that 18% of the patients that got upfront surgery turned out to have T1 to T2 N0 disease, in the preoperative chemoradiation arm, we probably overtreated around 20% of patients, but we just can't know because they had chemoradiation up front followed by surgery. In terms of other results, we did not see any change in the overall survival based on preoperative versus postoperative chemoradiation. And that's expected, right? Because we already know that adding radiation to surgery doesn't really change overall survival. And so the 5-year overall survival was just around 75% in both arms, not significantly different. What we did see is that that the local control significantly improved with the preoperative radiation compared to postoperative. So the 5-year local recurrence was 6% with the preoperative versus 13% with postoperative chemoradiation. And then the 10-year local recurrence was 7% versus 10%. So these are very important numbers to remember, and I would remember that the 10-year local recurrence was 7% with preoperative chemoradiation versus 10% with postoperative chemoradiation. So at 10 years, there was a 3% reduction in local recurrence with preoperative versus postoperative radiation. The other very important finding was the rate of downstaging with preoperative chemoradiation. So there was a 8% PCR rate, meaning pathologically complete response rate, with preoperative chemoradiation. So 8% of the patients that had preoperative chemoradiation at the time of surgery were found to have no pathologic signs of disease. There was also downstaging in terms of node-positive patients. So 40% of the patients in the post-op chemo-RT arm had node-positive disease, whereas only 25% of patients in the preoperative chemo-RT arm had node-positive disease. So what this implies is that there was some element of downstaging in that patients that were initially node-positive after receiving chemoradiation became node-negative. And then finally, the other element that we think about with downstaging is the extent of surgery that patients needed. So when they looked at a group of patients that were initially planned to undergo APR, so abdominal perineal resection, which remember sacrifices the sphincter and results in a permanent colostomy. So that is the more aggressive surgical approach that sacrifices the sphincter. Up front, when surgeons looked at these patients and deemed them necessary for an APR, in the postoperative arm, 20% of those patients actually ended up undergoing sphincter-sparing surgery. But in the preoperative arm, double that. So 40% of patients underwent sphincter-sparing surgery. So that's an important finding because it suggests that with preoperative chemoradiation, maybe we can convert some patients that would have otherwise needed APR to be able to then undergo sphincter-sparing surgery and have them not end up with a permanent colostomy. Overall, in both arms, the rates of sphincter preservation were around 70%. They did notice that in the preoperative chemoradiation arm, there was improved compliance, so 90% with preoperative versus 50% compliance with the postoperative arm. And this applied for both the radiation as well as chemotherapy. And if you think about it, again, it makes sense. After patients undergo this major surgery, it's probably harder for them to be compliant with the adjuvant radiation and then the chemotherapy. Whereas if they're getting some of the treatment up front, then maybe they're better able to be compliant. And then finally, they found no significant differences in toxicity between the arms. So the German rectal cancer study is an extremely important trial to be familiar with. Remember that it looked at patients undergoing TME and adjuvant chemotherapy and randomized them to preoperative versus postoperative chemoradiation. What they found is that preoperative chemoradiation significantly improves local control as well as sphincter preservation rates. The local control rates, so at 10 years, the local recurrence went from 10% with postoperative chemoradiation down to 7% with preoperative chemoradiation. So significant local control benefit. The one downside is that potentially we might be overtreating some patients. So remember that in those patients which underwent upfront surgery, it turned out that about 20% of them in fact had T1 to T2 and 0 tumors. So that implies that in the group that got upfront chemoradiation, maybe around 20% of them were actually overtreated. In the modern era, where we use MRIs for staging, and MRI was not routinely used in this German study, our hope is that that risk decreases because we are more accurately able to stage these patients with MRI. But that is an important caveat to be aware of, is that in the German rectal cancer study, probably around 20% of patients were overtreated. Despite that, this study shows that preoperative chemoradiation improves local control, and based on this study, preoperative chemoradiation then became the standard of care. So just to reiterate, because the German rectal cancer study is a very, very important study, remember we talked about how for short course radiation, this was standardly given preoperatively to begin with, but it was really the long course chemoradiation that we needed to kind of understand what was the optimal sequence. And so that is where the German rectal cancer study comes in. And they took patients with stage 2 to 3 rectal cancer and randomized them to TME with either preoperative or postoperative chemoradiation. Now, 20% of the patients in the post-op chemoradiation arm were downstaged to stage 1 disease at the time of surgery. And so probably 20% of the patients in this study were overtreated with chemoradiation. But what the study showed is that preoperative chemoradiation significantly improved local recurrence, but it did not have any benefit to overall survival. The 5-year local recurrence rates went from 13% down to 5% with preoperative chemoradiation. The 10-year local recurrence went from 10% down to 7%. There was an 8% PCR rate with preoperative chemoradiation. And in the preoperative chemoradiation arm, there were increased rates of sphincter sparing surgery among those patients that were originally planned to undergo an APR. So the big takeaway here is that preoperative chemoradiation improves local control and it improves downstaging. So now we've established that total mesorectal excision is the surgery of choice. In the TME era, adding radiation to surgery provides a local control benefit. Short course radiation is one option, and it's typically given 25 gray and 5 fractions radiation alone. Long course chemoradiation is another option. We know that adding chemotherapy to the long course radiation improves local control. And in the German rectal cancer study, we saw that giving preoperative chemoradiation improves local control compared to postoperative radiation. So both preoperative short course radiation and preoperative long course chemoradiation are options prior to TME. How do these two compare to each other? Do we prefer short course? Do we prefer long course? There have been many trials designed to answer this question. So let's take a look at these studies and what they found. The first trial that we'll go over was the Polish study, which randomized patients with clinical T3 to T4 resectable rectal cancers without any sphincter involvement to short course versus long course chemoradiation. The short course radiation arm received 25 gray and 5 fractions radiation alone, followed by TME within 7 days. The long course chemoradiation arm received chemoradiation, so 50.4 gray and 28 fractions with concurrent 5-FU and leucovorin, followed by TME within 4 to 6 weeks. So the timing between radiation and surgery was different in the arms. Postoperative chemotherapy was optional, and it turned out that patients were more likely to get postoperative chemo if they were in the short course radiation arm, which makes sense because these patients did not get any concurrent chemotherapy. The primary endpoint of this trial was rate of sphincter preservation, and it was actually designed as a superiority trial to show that long course chemoradiation is superior to short course radiation in terms of sphincter preservation. This primary endpoint of the trial was not met, so rates of sphincter preservation were just around 60% across both arms, not significantly different. The Other outcomes in terms of overall survival, disease-free survival, and local recurrence were also not significantly different. They did find that the rate of positive resection margin was 13% with short course radiation versus just 4% with long course chemoradiation. So that was significantly improved with the long course chemoradiation. But again, the trial was not designed for this endpoint. It was designed for rates of sphincter preservation. So bottom line from the Polish study, comparing preoperative short course versus long course radiation, the study found no significant improvement in their primary endpoint of sphincter preservation with long course chemoradiation. They found lower rates of positive resection margins with the long course chemoradiation, as well as a 5% trend towards improved local control. But again, the local control was not significant, and the study was not powered for this endpoint. So the big takeaway from the Polish study was no significant difference between the two arms in terms of sphincter preservation. TROG 0104 was a similar study to the Polish study, with a few differences. So just like the Polish study, they took patients with T3 rectal cancers and they randomized them to short course radiation followed by TME in 3 to 7 days versus long course chemoradiation followed by TME in 4 to 6 weeks. In this trial, however, they mandated all patients to receive adjuvant chemotherapy. So for the short course arm, it was 6 monthly cycles of 5-FU leucovorin. For the long course chemoradiation arm, it was 4 monthly cycles of 5-FU and leucovorin. And the Polish study was powered to detect superiority of the long course chemoradiation in terms of sphincter preservation. The TROG study was powered to detect the superiority of long course chemoradiation in terms of local control rather than sphincter preservation. Just like the Polish study, the TROG study did not show superiority of long course chemoradiation in terms of local recurrence. There was a trend towards improved local control, again, as we saw in the Polish study, but this did not reach significance. So the 3-year local recurrence was 7.5% for short course versus 4.4% for long course. The 7-year local recurrence was 7.5% for short course versus 5.7% for long course. So at 7 years, the difference was very, very small, less than 2%, and it was not significantly different. They found no significant difference in terms of distant metastasis-free survival, overall survival, or late toxicity between arms. There was a subset analysis that actually showed the cumulative local recurrence for distal tumors was 0% with long course chemoradiation versus 12.5% with short course radiation. But the main outcome that it was powered to show was negative. So it did not show superiority of long course chemoradiation in terms of local recurrence. So the TROG study, again, no significant improvement in local control with long course chemoradiation versus short course radiation. They did see a trend, just like in the Polish trial, especially for distal tumors, so closer to the sphincter, but did not reach significance. So that is the big takeaway from the TROG study, and I think it's fairly easy to remember because it kind of mirrors what we saw in the Polish study. Stockholm 3 was another trial that compared short course versus long course radiation. But I think more interesting than the comparison of the fractionation regimens was actually the comparison of the time interval between radiation and surgery. So Stockholm 3 took around 800 patients with rectal adenocarcinoma who were planned for APR, so that is the sphincter sacrificing surgery. And they randomized them to short course radiation followed by immediate TME within 1 week, just like we saw in the Polish and the TROG trials. The other arm was short course radiation followed by delayed TME in 4 to 8 weeks. And then there was a third arm looking at conventional radiation, 50 gray and 25 fractions, followed by TME in 4 to 8 weeks. In the long course radiation arm, of note, they did not involve concurrent chemotherapy. So they just had conventionally fractionated radiation without concurrent chemotherapy. So it was short course radiation followed by TME in 1 week, short course followed by TME in 4 to 8 weeks, or long course radiation alone without the concurrent chemo followed by TME in 4 to 8 weeks. And then around 15% of patients received adjuvant chemotherapy after surgery. Their primary endpoint was local recurrence, and they found no significant difference in the local recurrence rates between arms. So it was just around 3 to 5% at 5 years. They found no significant difference in the 5-year overall survival, which was around 75% across all arms, or the recurrence-free survival between any of the arms. What they did see is that the PCR rate significantly improved in the arm that received short course radiation followed by delayed TME. So the PCR rate was 0.3% with short course radiation followed by TME within 1 week, 2.2% with the conventionally fractionated radiation followed by TME in 4 to 8 weeks, and 10.4% PCR rate for short course radiation followed by delayed TME in 4 to 8 weeks. What they did find as well is that the postoperative complications were worse when patients received immediate TME after short course radiation. So the postoperative complication rates were 50% with that approach versus 38 to 39% when they had delayed surgery. So the Stockholm 3 trial, I think, is important because it shows similar oncologic outcomes in all arms, but less postoperative complications and significantly improved PCR rates with short course radiation followed by delayed TME. And if you think about it, it makes sense because when we delay the surgery, it actually gives patients longer time to respond to radiation. We know that radiation, especially when we give kind of hypofractionated radiation, we're giving 25 gray in just 5 fractions, we know that radiation continues to have an effect for weeks after. And so when we give patients a longer time to respond to that radiation, they have a higher PCR rate. Additionally, if we delay surgery by that much, 4 to 8 weeks, then perhaps there's some potential to actually give some preoperative chemotherapy in the weeks between short course radiation and TME. So I think the Stockholm 3 trial is a little bit limited in the comparison for the long course radiation arm because they did not give any concurrent chemotherapy. However, I think it's interesting because it shows that delaying TME after short course radiation seems to provide a PCR benefit, and perhaps we can squeeze in some chemotherapy in those weeks between radiation and surgery. The Stellar trial then, which was published much more recently compared to all of these trials, it was published in 2022, did exactly that, and it took around 600 patients with distal or middle third rectal cancers, clinical T3 to T4 or node positive, and randomized them to short course total neoadjuvant therapy, so 25 gray in 5 fractions, followed by Capox, so capecitabine and oxaliplatin for 4 cycles, followed by TME 6 to 8 weeks after the radiation, followed by another 2 cycles of Capox. And they compared it to long course chemoradiation, so 50.4 gray in 28 fractions, plus capecitabine, followed by TME after 6 to 8 weeks, followed by Capox times 6 cycles on the back end. And they required IMRT technique for radiotherapy. And they found that the primary endpoint of 3-year disease-free survival was non-inferior between the arms. So the 3-year disease-free survival was 64% versus 62%, and this was non-inferior. And the trial was powered to show non-inferiority of these approaches. The 3-year overall survival, interestingly, was significantly improved in the short course total neoadjuvant therapy arm. So the overall survival was 86% versus 75%. Now, this needs to be taken with a grain of salt because there was also higher compliance rates with long course chemoradiation versus short course total neoadjuvant therapy. So 93% in the long course chemoradiation arm got the full dose of chemotherapy versus just 75% in the short course total neoadjuvant therapy arm. So it's not clear that short course improves overall survival. I would not necessarily draw that conclusion, but just to note that that was one of the findings from this trial. The PCR rate was significantly higher with short course total neoadjuvant therapy, so 22% versus 12%, and they found no significant difference in the disease-free survival or the local control between arms. They did find significantly worse grade 3 to 4 acute toxicities in the short course total neoadjuvant therapy group. So Stellar found that disease-free survival was non-inferior between short course total neoadjuvant therapy and long course chemoradiation. I would not say that this showed that short course total neoadjuvant therapy was better, but rather it kind of introduced this idea of total neoadjuvant therapy where we give radiation up front, and then in order to improve PCR rates, we saw in Stockholm 3 that delaying TME up to 8 weeks out from radiation can kind of help. So in those weeks between the radiation and the surgery, we actually squeeze in some chemotherapy up front, and it seems that that helps to improve the PCR rates. So the Stellar, I think, is important because it kind of introduces this idea of total neoadjuvant therapy. But if you think about it, it doesn't really head-to-head compare short course versus long course, because in the long course chemoradiation, they were not receiving total neoadjuvant therapy, but rather therapy similar to what we saw in the German rectal cancer study, where they got preoperative chemoradiation, followed by surgery, followed by adjuvant chemotherapy. This brings us to the Rapido study, which was designed very similarly, I think, to the Stellar trial. And it also compared preoperative short course total neoadjuvant therapy versus long course chemoradiation, followed by TME, followed by adjuvant chemotherapy. This trial was different than Stellar because it included, I think, more high-risk patients. So they included patients with only clinical T4A to T4B disease, and they could have nodes positive or negative. So they had kind of more locally advanced tumors, and they randomized these patients to short course radiation, followed by Capox for 6 cycles or FOLFOX for 9 cycles, followed by TME. Or they randomized them to long course chemoradiation with capecitabine, followed by TME, followed by the option of adjuvant Capox or FOLFOX. So very similar design to Stellar, but including more clinical T4A to B patients, so higher risk, more locally advanced patients. When the 3-year results of this study were published, it seemed very, very promising because the 3-year disease-related treatment failure was lower with short course radiation, 24% versus 30%. The local recurrence rates were 8% versus 6%. The distant metastasis rate was actually lower with short course radiation, so 20% versus 27%, and the rate of PCR was twice as high, so 28% with short course versus 14% with the long course. And the 3 years overall survival was very good, 89% in both arms. There was an update that was published more recently. This was the 5-year update, and the results actually then showed worse local control with short course TNT. So with longer term follow-up, short course radiation seemed to be inferior to long course chemoradiation in terms of local control. So the local recurrence was 12% with short course versus 8% with long course. And when they looked only at the patients that had R0 or R1 resections, that was statistically significant. So the local recurrence rates were 10% with short course versus only 6% in long course radiation. So the Rapido trial, I think, was important because it was one study where the more mature results, so the 5-year results, actually showed worse long-term local control with short course radiotherapy. And you have to keep in mind that this study enrolled patients with more locally advanced disease. So clinical T4A to T4B disease, not just, they didn't include T3 necessarily, T4 patients. So we just went through a whole host of studies looking at short course versus long course radiation, and many of them had subtle differences in terms of the study design. And the question becomes, how do we interpret these studies? What do we make of these studies? So we first talked about the Polish study, the TROG study, and Stockholm 3 studies, which showed no real significant difference between short course and long course radiation in terms of local control. Stockholm 3 introduced this idea of delaying the TME to allow for about 8 weeks after radiation. And then Stellar and Rapido introduced this idea of total neoadjuvant therapy, or TNT, where we take that gap between radiation and surgery and we actually insert some cycles of chemotherapy in the neoadjuvant setting. So it's total neoadjuvant therapy. The thing with Stellar and Rapido is that these were not really a direct comparison between short course and long course approaches. These trials introduced the TNT approach in their short course arms. And there were some disparities in terms of how much chemotherapy the different arms received, as well as the compliance rates. And that could definitely play into the different outcomes that we saw. So we saw improved overall survival outcomes with short course in the Stellar trial. We saw improved disease-free survival outcomes in Rapido. So I think it's important to kind of keep in mind that there were some differences in terms of how much chemotherapy these arms actually received, as well as their compliance rates. I think a very important takeaway from the Rapido trial is that the 5-year local failure rates were worse with short course TNT compared to long course chemoradiation, even though the PCR rates were higher with short course TNT. And we saw even in Stellar that PCR rates were higher with the short course total neoadjuvant. So importantly, PCR is not a surrogate for local recurrence or improved outcomes in any way. So we can't use PCR as a surrogate for oncologic outcomes. And we also really need to keep in mind that while Rapido showed worse local failure in the short course arm, they also enrolled higher risk patients than many of the previous trials that we discussed. So they had clinical T4 patients, and they also had lower lying tumors. So in terms of the big takeaways here, I would not conclude that short course radiation leads to worse local control compared to long course chemoradiation, because that is probably not true. Remember that Rapido was the trial that showed worse local control at 5 years with short course radiation, even though they had higher PCR rates. But Rapido enrolled much higher risk patients than what we saw in many of the previous trials that we discussed, such as the Polish trial, the Trog trial, Stockholm 3. Remember, Rapido had clinical T4 and lower lying tumors. So rather than saying that short course leads to worse local control always, what I would probably conclude is that short course radiation is not always non-inferior to long course chemoradiation based on Rapido. And for higher risk patients, there's probably reason to consider long course chemoradiation. So if patients have a T4 primary, if they have node positive disease, especially extra mesorectal nodes, if they have involvement of mesorectal fascia, they have low lying tumors, so either the lower third of the rectum or involvement of the sphincter or the anal canal. And also if they are planning to undergo non-operative management. Remember, we need more data on kind of short course radiation followed by a wait and watch approach. Most of the studies that have looked at omitting surgery, which we will talk about here shortly, most of these studies have looked at long course chemoradiation rather than short course. So we don't have a lot of data on short course radiation followed by observation. So if there's any doubt as to whether or not this patient will make it to surgery, it's probably safer to give long course chemoradiation. And I would say in the United States, I do think that it's more standard to give long course chemoradiation, because remember, historically, that has kind of been the standard here in the US. So short course radiation, I think, has its utility in select cases, but especially if we don't know whether the patient's going to make it to surgery or if they have a more high risk tumor, so more locally advanced, low lying, involved nodes, I definitely would consider long course chemoradiation over short course. So this then brings us to the last segment of that evolutionary arc of the management of rectal cancer that we talked about. You know, we already talked about kind of optimizing our surgery with TME, optimizing our radiation approaches with short course radiation or long course chemoradiation. We then talked about sequencing and talked about the benefit of preoperative chemoradiation and this new idea of total neoadjuvant therapy where we give both the radiation and the chemotherapy up front prior to surgery. And that brings us then to that last question of, well, do we need to be doing all of these therapies? Can we maybe omit either surgery or omit radiation? And so that first question of can we omit surgery comes from TNT. So if we do total neoadjuvant therapy where we give radiation up front and then we give more chemotherapy, is it possible that some of these patients can actually have a complete response and be managed with observation and maybe just not have to undergo surgery? And so let's talk about some trials that have looked at this idea of organ preservation with total neoadjuvant therapy. The OPRA study was a phase 2 study out of Memorial Sloan Kettering Cancer Center, which looked at this idea of organ preservation with total neoadjuvant therapy. So OPRA stands for organ preservation in rectal cancer. This study took around 300 patients with stage 2 or stage 3 rectal cancers, and these patients were staged with MRI, colonoscopy, and CT imaging. And they were randomized to one of two different arms of total neoadjuvant therapy. So the first arm was induction chemotherapy with FOLFOX or CAPOX, followed by chemoradiation with long course radiation up to 54 gray with concurrent capecitabine or 5-FU. So they got induction chemo followed by chemoradiation. The second arm was the same thing but flipped. So they got chemoradiation first and then consolidation chemotherapy with FOLFOX or CAPOX. At 8 to 12 weeks after total neoadjuvant therapy, the patients were restaged with DRE, FlexSig, and MRI. And if they had a complete clinical response or a near complete clinical response, they were observed with watchful waiting. And if they had an incomplete response, they went on to get a TME. I think it's important to realize what watchful waiting entails. Because it's not just observation, it's actually very close examination. So these patients need to be followed every 4 months for the first 2 years with digital rectal examination and flexible sigmoidoscopy. And then after 2 years, they then go to every 6 months for the following 3 years. So it's 5 years of very close observation. So at first, it's FlexSig and DRE every 4 months. And then after 2 years, it goes to every 6 months. So watchful waiting is pretty stringent, and we need to realize that not all patients can be compliant with that. So that's something we need to take into account if we're even going to think about offering this. But that said, that was the watchful waiting protocol that they observed in the OPRA trial. So if patients had either a complete or a near complete clinical response, they went on to observe with watchful waiting. So it turned out that 74% of the patients in the trial were able to enter that watchful waiting arm, and then 40% in the induction chemo versus 27% in the consolidation chemo arm ended up having tumor regrowth that required TME at a later time point. The vast majority of cases were within the first 2 years. The primary endpoint of this study was disease-free survival in patients treated with TNT followed by watchful waiting compared to historical controls. And they actually found that there was no significant difference in the disease-free survival in the patients in the OPRA trial compared to historical controls. The 3-year disease-free survival in this study was 75%. The 3-year local regional failure-free survival was 95%. Distant metastasis-free survival, 83%, and overall survival, 94%. And these results were all very similar across both arms, whether they received induction chemo or consolidation chemo. They did find that organ preservation rates were significantly higher in the arm that received chemoradiation followed by consolidation chemotherapy. So organ preservation was 53% in that arm versus 41% with induction chemo followed by chemoradiation. And that was significant, although the trial was not powered for this specific analysis. So the OPRA trial is very important because it is phase 2 evidence that with total neoadjuvant therapy for carefully selected patients, up to 50% of patients can actually achieve organ preservation with high rates of disease-free survival and overall survival. And those patients who do end up having a recurrence, that recurrence is typically seen within the first 2 years, and they can be successfully salvaged with total mesorectal excision. So with this novel approach of total neoadjuvant therapy followed by watchful waiting to see if we can try and avoid surgery in good responders, there has been a push to try and better optimize the radiation dose that we give these patients up front. So standardly with external beam radiation, we have given anywhere from around 50 gray to up to maybe 54 gray with conventionally fractionated radiotherapy. And that dose is kind of determined by the normal tissue constraints of the rectum and surrounding organs such as the small bowel. There are ongoing efforts to try and increase the dose that we can give to the rectum by using techniques such as brachytherapy. So one study that looked at a specific technique known as contact X-ray brachytherapy was the OPERA study. So OPERA was a phase 3 study out of France and the UK, and it's OPERA spelled O-P-E-R-A, not to be confused with the OPRA organ preservation and rectal adenocarcinoma study that we just talked about in the prior slide. So the OPRA study was a phase 2 study using pure external beam radiation, and that was out of Memorial Sloan Kettering. The OPERA study is a phase 3 study that came out of France and the UK, and it looked at contact X-ray brachytherapy boost. So this study enrolled patients with earlier stage disease, so clinical T2 to T3 node negative, or even node positive disease with less than 8 millimeter nodes, and the tumor had to be involving the low to mid rectum with less than 5 centimeters diameter. And all of the patients first underwent 45 gray and 25 fractions external beam radiation with concurrent capecitabine, and then they were randomized to either 9 gray and 5 fractions external beam radiation for a total of 54 gray, or a boost of 90 gray in 3 fractions using contact X-ray brachytherapy. The machine that they used, there's some representative pictures shown in the image here on this slide, but this is a special machine that delivers contact X-ray brachytherapy. It's different than an HDR brachytherapy machine, and this specific machine is not available at many centers in the US. So this study, as I said, came out of France and the UK. The results showed that there were significantly higher rates of 3-year organ preservation in the patients that received the contact X-ray brachytherapy boost. So the 3-year organ preservation was around 60% with the external beam boost to 54 gray versus 80% with the brachytherapy boost. And the organ preservation rates were extremely high for tumors that were less than 3 centimeters. So they were as high as 97% in the brachytherapy boost arm. Fewer patients in the contact brachytherapy boost arm had to undergo TME. So TME was done in about 40% of patients that got the EBRT boost versus less than 20% of patients that got the brachytherapy boost. And then the 3-year local control rates as well as the 3-year survival rates were very good in both arms. 3-year survival was around 98%. 3-year local control rates were around, or local recurrence rates were around 20% in both arms. They did see higher rates of acute proctitis and late bleeding related to telangiectasias in the brachytherapy boost group. So the OPERA trial was a phase 3 trial, and it showed excellent local control and organ preservation rates with chemoradiation, followed by the contact X-ray brachytherapy boost. Now, keep in mind, there's very few centers in the United States that are actually equipped with the specific brachytherapy machine that was used in this trial. In the United States, most centers are equipped to perform HDR brachytherapy, and there's actually an ongoing phase 2/3 study called the Morpheus study that is looking at an HDR brachytherapy boost for rectal cancers. So similar to the OPERA phase 3 trial, this trial is enrolling patients with clinical T2 to T3 disease, node negative, and they have to have less than or equal to 5 centimeter rectal tumors that occupy less than or equal to 50% of the circumference, and they're located within 10 centimeters of the anal verge. So we're looking at more low-lying tumors that could threaten the integrity of the sphincter. And the patients are being randomized 1-to-1 to get, similar to what we saw in OPERA, either 54 gray total with the external beam radiation or 45 gray to the pelvis, followed by image-guided adaptive HDR brachytherapy boost to a dose of 30 gray in 3 weekly fractions. Now, the interim phase 2 results were already published, and they found that the rate of clinical complete response was 50% with external beam versus 90% with the HDR brachytherapy boost. The 2-year TME-free survival was around 40% with external beam versus almost 80% with the brachytherapy boost. And so the phase 2 results showed that this approach is feasible and safe, and we are now trying to accrue to the phase 3 component of this study. So OPERA, as we saw, was the phase 3 trial looking at contact X-ray brachytherapy boost, and now we have the ongoing Morpheus study that is looking at HDR brachytherapy boost for clinical T2 to T3 patients with the goal of avoiding surgery. With the total neoadjuvant therapy approach, besides just altering the dose of radiation that we give, the other piece that we can alter is the intensity of the chemotherapy that we give, right? Because we usually give chemoradiation followed by chemotherapy, and then it's either surgery or wait and watch. So to try and improve the response to upfront neoadjuvant therapy and help improve kind of the complete response rates, another approach that we can take is to alter the chemotherapy, and that's exactly what the ongoing phase 2 to 3 Janus study is doing, which is an NRG and alliance study as well. So it's NRG GI 010, and it's also known as the Janus study. So this study is looking at patients with locally advanced rectal cancer, so either T4, node positive, or T3N0 that will require surgery. And they are randomizing patients to either get long course chemoradiation followed by standard doublet chemotherapy, which is either FOLFOX or CAPOX. And then the other arm is long course chemoradiation followed by FOLFIRINOX. So they're doing triplet chemotherapy and adding irinotecan to that FOLFOX regimen that we standardly do. So the primary endpoint of the phase 2 component is the clinical complete response rate, and then for phase 3 it'll be disease-free survival. So the Janus trial is also going to be very interesting because we will find out if intensifying chemotherapy can also help increase organ preservation rates. For the sake of time, I won't get into all of these studies, but other than the Janus trial, there are a few other trials also looking at organ preservation for locally advanced rectal cancer. So this is definitely an exciting area of investigation, and we're really, as a field, trying to do everything we can to figure out how we can optimize the total neoadjuvant therapy so as to avoid surgery, especially for patients with lower-lying tumors that would require sacrifice of their sphincter. So we talked a lot about organ preservation and that phase 2 OPERA trial that showed even with kind of current standards, which include long course chemoradiation followed by chemotherapy, we can actually achieve clinical complete response in up to 50% of patients and spare them from having to go surgery. The other side to the coin is, are there patients that might benefit from the omission of radiation therapy? Are there cases where we might consider giving chemotherapy up front, followed by surgery, and then omitting radiation altogether? The Prospect trial was an important clinical trial that was published fairly recently, and it looked at this question of omitting radiation therapy for select patients. So the Prospect trial recruited over 1,000 patients with either clinical T2 or T3 disease who were deemed eligible for sphincter-sparing total mesorectal excision. So these were not patients with low-lying tumors or tumors with sphincter involvement. They were patients that off the bat were going to be eligible for sphincter-sparing surgery. And they were clinical T2 to T3 with or without node positivity. These patients were randomized to either FOLFOX for 6 cycles, and then if they had a 20% or higher decrease in the size of their tumor on imaging, as well as proctoscopy and exam, they then underwent total mesorectal excision, followed by adjuvant chemotherapy. And then if patients were unable to receive at least 5 cycles of upfront chemotherapy, they got chemoradiation. And also if they were unable to get an R0 resection, they were recommended to have adjuvant chemotherapy chemoradiation therapy, which ultimately 10% received adjuvant chemoradiotherapy. The other arm was chemoradiation with concurrent 5-FU or capecitabine, followed by total mesorectal excision, followed by an optional 8 cycles of adjuvant FOLFOX, which was received by 78%. The Prospect trial showed that the 5-year disease-free survival was non-inferior with chemotherapy alone. So the disease-free survival was just around 80% in both arms, and it met the criteria for non-inferiority. The 5-year overall survival was around 90% in both arms, and the 5-year rates of local recurrence were very similar, just shy of 2% in both arms. The rates of R0 resection were around 90% in both arms, and in terms of grade 3 or higher toxicity, they found that that was present in 41% of patients that got neoadjuvant FOLFOX versus 23% of the patients that got chemoradiation. So the Prospect trial showed that for clinical T2 node positive or clinical T3 node negative or positive rectal cancers that upfront were eligible for sphincter sparing surgery, this approach of preoperative FOLFOX followed by surgery if they had at least a 20% response was non-inferior to preoperative chemoradiation. So it's important to realize that this is an option for patients. It's also important to realize that the Prospect trial excluded patients that had T4 tumors, high level of nodal involvement, or concerned that they would not be eligible for sphincter sparing surgery. So it's also important to realize which patients this may not be an option for. The Prospect study is important to know because it kind of applies to all comers with rectal cancer. The other trial that's very important to know that looks at the omission of not just radiation but also surgery for a very select group of patients with rectal cancer is this study of PD-1 blockade for patients with stage 2 to 3 rectal cancer with MMR deficiency. So if you haven't already watched the overview lecture, in that talk we have an in-depth discussion on what is deficient MMR, what is microsatellite instability, and why is that important for rectal cancer. But the bottom line is patients with either MSI high or deficient MMR respond very well to immunotherapy. And this particular phase 2 trial, when it was published, had astonishing results, and it made a lot of headlines, and patients would hear about this and they actually would come in and ask about this treatment because the headline was rectal cancer can be cured with a single drug. But there's a lot of nuance to this, and so let's talk about what the trial showed and who the study might actually be appropriate for. So in this particular trial, it was a phase 2 study that enrolled patients with stage 2 or 3 rectal cancers that had deficient MMR. So they had to have loss of expression of one of their mismatch repair proteins on immunohistochemistry. So loss of expression of either MLH1, MSH1, MSH6, or PMS2. If they met those criteria and had deficient MMR, and keep in mind no patients in this study had Lynch syndrome, they just had the sporadic MMR deficiency. They were then treated with dostarlimab, which is a PD-1 inhibitor, followed by long-course chemoradiation with capecitabine with plan for TME thereafter. The dostarlimab was administered as 500 milligrams per meter squared every 3 weeks for 9 cycles, so for 6 months total. They evaluated tumor response on MRI, PET scan, endoscopy, and digital rectal exam every 3 months. At a median follow-up of 12 months, 100% of patients had a sustained, complete clinical response just to dostarlimab alone, and they had not required any chemoradiation or total mesorectal excision. 81% of patients had a resolution of symptoms within 9 weeks of initiating dostarlimab, and they found no grade 3 or worse adverse effects. They did see some grade 1 to 2 side effects of dermatitis, pruritus, and fatigue. And so, as you can see, this was an incredible study, right? Because they had 100% complete clinical response just to dostarlimab alone. But it's important to realize that the sample size of the study was only 12 patients. It was a phase 2 single-arm study. They had to have deficient MMR, but no patients in this study had Lynch syndrome. And these were very early results at just 1 year follow-up. They did present updated results at ASCO 2024, and they showed that there were sustained clinical responses in a total of 20 patients at 28 months, and these patients were at least 2 years out, and 41 patients in total had been started on this regimen. So the sample size is very small, but it shows very promising and very excellent results that patients with deficient MMR rectal cancers have excellent response to neoadjuvant immune checkpoint inhibition, and they do need very close monitoring, but a lot of these patients may be able to avoid local therapy altogether. So they don't just have to omit radiation, they can also omit surgery and just get treated with the drug alone. So deep breath, because we finally made it to the end of all of the studies I wanted to talk about. I know this has been a long talk here, but some of the major takeaways from this last section where we talked about kind of de-escalation of therapy. Really, de-escalation of therapy is an option that has been studied mostly for T2 to T3 disease, and there's two different branches. So one option is to look at the omission of radiation. The other option is to pursue organ preservation and look at the omission of surgery. In terms of omission of radiation, the best evidence we have for that is from the Prospect study that looked at preoperative FOLFOX followed by TME if patients had at least a 20% response. And remember, the patients that were enrolled on Prospect had either T2 to T3 tumors, and they also were eligible for sphincter-sparing surgery up front. There are many other trials that either have been published or are ongoing looking at organ preservation. So the OPRA trial was a phase 2 trial that looked at chemoradiation followed by consolidation FOLFOX or CAPOX, followed by watchful waiting, and up to 50% of these patients achieved organ preservation. And there are many ongoing efforts to try and improve that number of patients that achieves organ preservation. So OPERA was that phase 3 study of contact X-ray brachytherapy boost that came out of Europe. There is an ongoing Morpheus study looking at HDR brachytherapy boost. And then there's an ongoing Janus study as well, looking at can we intensify the chemotherapy to try and improve rates of organ preservation. And the Janus study is including T4 patients as well. And then finally, for our patients that have microsatellite instability high or MMR deficiency, we know that these patients respond better to immunotherapy. And there is data for immune checkpoint inhibition with dostarlimab, and the phase 2 study that was published showed 100% clinical complete response rate for patients with MMR deficiency that were treated with upfront dostarlimab. And so I think those patients with the deficient MMR kind of fall into a different group, and they can have significant de-escalation of therapy. So just to summarize our treatment paradigm for rectal cancer, which we talked about in the overview lecture, remember that for most patients with clinical T1 to T2 N0 disease, surgery alone is an option. And if they meet certain criteria, they can be candidates for transanal resection, or they can undergo total mesorectal excision. And they don't typically need radiation and chemotherapy. For certain low-lying T2 tumors, however, where sphincter preservation may be very challenging, these patients, we might consider treating them with chemoradiation and then restaging them and seeing if they need surgery. For most patients with locally advanced rectal cancer, and remember when we say locally advanced rectal cancer, we are thinking about T3 to T4 tumors or anything that is node positive, so stage 2 or higher disease. Most of these patients are going to fall into our group of patients that have proficient MMR or microsatellite stable disease. And so for most of these patients, we're going to treat them per the standards that we kind of talked about in this lecture. So for patients that have upper tumors that are T2 to T3, they may be treated per the Prospect paradigm. So that involves chemotherapy. And if they have at least a 20% response, then they go on to get TME with or without adjuvant chemotherapy. Or if they have low-lying tumors that are T2 to T3 or T4 tumors, we can treat them with a total neoadjuvant approach where we give chemoradiation. Typically, it's going to be long-course chemoradiation followed by chemotherapy with either FOLFOX or CAPOX, and then they can either be treated with watchful waiting, or if they don't have a good response, then they go on to get surgery. And then finally, we have our deficient MMR or MSI high patients, and as long as they are candidates for immunotherapy, they can be treated with immune checkpoint inhibition, such as dostarlimab alone, and then go on to get watchful waiting. And if they have persistent diseases at 6 months, they can be treated with chemoradiation and surgery. However, based on current results, it seems that the vast majority of these patients respond very well to upfront immune checkpoint inhibition. That brings us to an end of our discussion of the evidence base for management of locally advanced rectal cancer. I apologize that this talk also went a little bit over an hour. I was hoping to keep it shorter than that, but there's just a lot to cover with rectal cancer. Again, we did not cover every single trial that we could have covered, but hopefully with the data that we did show, we kind of helped to contextualize the evolutionary arc of the management of locally advanced rectal cancer. And, hopefully you understand how the role of radiation has shifted, how the sequencing has shifted, and how our future directions are really revolving around organ preservation or trying to de-intensify therapy by omitting radiation. So I hope that this was helpful to you, and I thank you so much for your time and attention.